Thank you so much for joining us today for When Eating Hurts, Navigating Disorders of the Gut and Brain Interaction, Jessie Haggerty. Before we jump into today's workshop, I just want to let folks know that we have our national conference coming up April 30th and May 1st, and today happens to be the last day of early bird pricing. So if you would like to come and want a really good price on admission, we encourage you to register today. And we hope to see you all there. It's always a really fun conference to come to. I know I'm biased, but I think that it is. Thought that before I worked here. And with that, I am really happy to introduce Jessie Haggerty. So Jessie is a registered dietitian with clinical expertise in eating disorders and weight-inclusive care. She's previously owned a private practice specializing in eating disorder treatment and health at every size, aligned nutrition counseling. Jessie now practices at Boston Children's Hospital in the Motility and Functional Gastrointestinal Disorders Clinic, where she works with pediatric and adolescent patients with motility disorders and disorders of the gut-brain interaction. Her area of interest is in navigating the overlap between gastrointestinal symptoms and disordered eating, and the emphasis on collaborative and developmentally attuned care. So, Jessie, we're so excited to have you, and I'm turning it over to you.
Thanks for having me. And so nice to kind of see everyone. I know I'm looking at a lot of names right now, so no pressure to turn cameras on because I probably won't be able to see you while I'm presenting anyways. But I'm gonna share my screen. So thanks for that introduction, Monica. That was really nice. So yeah, today I'm talking about this kind of overlap between disorders of gut-brain interaction in adolescent eating disorder treatment. And right now I'm primarily working with adolescents. I've worked with adults most of my career. So I think everything that I'm talking about today is like absolutely applicable to the adult population as well. All right, here we go. We just did a quick intro, so I won't spend too much time here, but I've spent about 10 years in private practice doing health at every size, aligned eating disorder treatment and medical nutrition therapy. And then kind of developed a special interest in pediatric nutrition after having my own children, as you do. So once I had my daughter, my second child, I closed down private practice for the most part, and I'm now working at Boston Children's in the Motility and Functional Gastrointestinal Disorder Clinic. And I work as part of a multidisciplinary team. So we work with two gastroenterologists, Dr. Sam Nurko and Dr. Beate Beinvogel, and I'm mentioning them specifically because I've borrowed a lot of their analogies for today's presentation, as you'll see. We have nurse practitioners, a GI psychologist, a social worker, myself, and then we also have a pain physician in our abdominal pain clinic. And clearly between these two clinics, or between my private practice and this work, have really developed this special interest in the overlap of these symptoms or of these disorders. And I think my interest probably stemmed actually from like a meta talk years ago with Marcy Evans and Lauren Deere. So I know the two of them have like an amazing GI and eating disorder course if, anyone is looking to learn more. But I think my own interest definitely kind of stemmed from that talk here. So this is kind of like a full circle moment. So here, some objectives for today is just to describe this overlap between these two disorders, identify some pathways in which these disorders influence one another, recognize the clinical challenges, which I could present on that for days probably. And then we'll apply some practical nutrition advice, and if we have time, we'll do a case study, but I really want to make sure we have time for questions at the end. And that being said, I naturally talk very fast, and I am probably going to talk a little bit faster just to make sure we get through everything. But honestly, if it ever is too much, then please tell me to stop and slow down. You could unmute at any time. So we'll just do a quick definition of what even are DGBIs. There's so many people here, which is amazing. And I know that we're probably all coming from different levels of understanding of these conditions. Rome Foundation describes disorders of gut-brain interaction as these group of disorders with chronic or recurrent GI symptoms in the absence of structural disease. So this is not irritable bowel disease or celiac disease, although patients with those conditions can also have DGBIs. And they're no longer considered a diagnosis of exclusion. So I see a lot of patients who say like, oh, my doctor ran all these tests, they couldn't find anything, so they just gave me this IBS diagnosis. The diagnoses now really are based on symptoms, although providers might order like further tests or imaging to rule out any underlying pathology. So these GI disorders are really characterized by this dysregulation between the communication between your gut and your brain. We'll talk a lot today about visceral hypersensitivity, and then these are also characterized by altered GI motility. So constipation, diarrhea, gas, bloating. We'll talk just a lot about poop today, I'm sure. And the examples that I'm going to really focus on today are irritable bowel syndrome and postprandial distress or functional dyspepsia, because they're pretty much the most well-researched disorders of gut-brain interaction that overlap with eating disorders. But I will say, just anecdotally, I've kind of seen overlaps in all of these. So I think there's a lot more research to be done in this area. So a little bit about this overlap here. We kind of have what we were just talking about with DGBIs, and I'm assuming because we're at Meta, like I'm not going to do a lot of eating disorder like extra training today. We kind of know how these disorders can present. But I think by the time these patients individually, like whether they have a DGBI or an eating disorder or both, by the time we as dietitians see them, we kind of see some sort of this overlap of like there's food fear or avoidance, maybe progressive dietary restriction. There's distress around meals, whether that's due to pain or due to fear of your body changing. And then often we see like nutritional compromise, which might be weight loss or micronutrient deficiencies, electrolyte imbalances. So here are some of the statistics. If we don't know this already, but 42 to 98%. So I'm going to say, let's say at least half of eating disorder patients meet criteria for at least one DGBI, and almost half meet criteria for 3 or more. So think about the patients that you work with, maybe half of them might have one of these disorders happening simultaneously. IBS is the most common. And then functional dyspepsia, specifically that postprandial distress, that early satiety, that pain with eating, can affect 90% of patients with anorexia or bulimia. And then we see constipation is present in about 40% of patients with anorexia, which is pretty significant. We see that a lot of these eating disorders might kind of have this secondary DGBI. That's what these stats show. With the exception being that we see a lot of patients with a DGBI who then go on to develop these ARFID symptoms, this fear of aversive consequence, this fear of eating in general or eating a specific food that might trigger their GI symptoms. While we see kind of patients with like primary ARFID have lower DGBI rates, although I think 30% is still pretty notable. One thing that I see that I'm definitely kind of interested in kind of tracking a little bit more is that it's not, at least not, I've not found, like it's not very well documented that ARFID can like turn into anorexia, right? But what we tend to see is that there's a DGBI, there's this kind of development of this fear of aversive consequence with food or with eating. And then there's weight loss that happens. And a lot of my adolescent patients kind of look at this weight loss as like a benign consequence. Like, oh, okay, well, I just lost weight, but like, that's not really the problem. And then they maybe develop, fear might be too strong of a word, but like resistance to regaining that weight back. And we'll see why that can be a problem in some of the other research that we'll talk about. But I just kind of want to keep that in the back of your mind, because I think that's just something that I tend to see a lot, and there's not been, too much research around this kind of what happens when our patients kind of get to that point. So this little cycle that I just kind of drew this up based on my experience is that we see these GI symptoms start. We see this food avoidance, like we were just talking about, leads to overall reduced intake and malnutrition. Malnutrition can cause worsening GI function, which we'll talk more about. And then we see increase in symptoms because of that. And then what I also see a lot is this kind of fixation on symptoms, right? So patients start to become really fixated on identifying food triggers. Maybe there's food tracking that has nothing to do with calories, but is more about symptom tracking, or just fixation on like visceral sensations of like feeling constipated or bloated. And then again, kind of like the cycle continues. And sometimes the cycle starts here, right? The cycle starts with the reduced intake that has nothing to do with the GI disorder. And then that can kind of in turn lead to the GI disorder. So what we can see in the research is that malnutrition, regardless if it is related to the eating disorder, can affect motility. It can affect gastric emptying and colonic motility. And some studies show that whole gut transit time, like from eating to passing a bowel movement, can take twice as long in patients with anorexia and in anorexia. And so almost twice as long, so 66 hours compared to 38. And what we're really finding is that it's malnutrition. It's separate from like the psychological factors that might come along with the eating disorder as well. So I know this is the title of the talk, right? So when eating hurts, and I kind of want to pause for a second if I can figure out how to look at the chat. But I am curious. Here we go. Is this like something that everyone has experienced where patients complain of pain when eating or nausea? I would put under the pain umbrella. Okay. Okay. Yes. 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 That's why we're all here. That makes sense. Nausea, pain, discomfort. And I'm curious if, like, have your patients been told, not, I know not by you, but by another provider, that it's like all in their head, that it's psychosomatic, that it's their eating disorder talking? Like, also, yes. Okay. Yeah. Unfortunately, yes. Yes. Very unfortunately. Yeah. Yeah. Yes. They need to push through. Mm-hmm. Totally. Very frustrating, very dismissive. And it is, I'll just kind of start with like, of course it's challenging because we all need to eat, right? And so, but it's like, how do we build the framework for this to be, this pain to kind of be honored and as part of the recovery process? So we'll just talk a little more about that, but I'm glad everyone, I'm not, no one's going to be like, what, what are you even talking about right now? Um, so I'm going to talk a little bit about visceral hypersensitivity. And this is a term and condition that we talk about a lot in the clinic that I work in. But I've, clearly kind of developed some more interest in like, how does this overlap with the eating disorder? So just quick definition, visceral hypersensitivity is an increased response to normal physiological stimuli. And that can lead to chronic visceral pain. So some ways that this is measured in the research, not in our clinic, in the research, is like balloon distension in the stomach or even in the rectum. But imagine like having like a balloon in your stomach and they're going to measure, if I blow it up this much, how much pain are you going to experience? And people with visceral hypersensitivity, right, next to someone without, we can blow the balloon up the same exact amount. One person experiences pain and the other person doesn't. So there's this heightened sensitivity of the gut to like any distension, any little change, even if it's like normal or within normal limits. So it's not something that we can really like measure. Like we can't send someone to do a test for it. We can do a subjective test using this visceral sensitivity index or the VSI here. But this is not something that we would test for. It's really, again, based on symptoms and patient report. So This is a analogy I'm borrowing from our MD, Dr. Nurko, is like imagine you have a sunburn on your arm and you tap it and it hurts because it's burned. The nerves become hypersensitive, right, because of the burn. If the burn goes away and you tap it, it doesn't hurt. This hasn't changed. The tapping hasn't changed. The input hasn't changed, but the response, the pain response, the sensitivity, and how your brain is perceiving the pain has changed. So again, like the nerves of the gut wall become hypersensitive. So even if something normal happens, like eating anything, even a normal amount of food, that can be painful. The other things that can be triggers of this pain are like gas or osmotic pressure. That's why in the GI world, like everyone recommends this low FODMAP diet because those foods can increase gas or pull water into the intestines. Stool burden or constipation, like even a normal stool burden can cause pain in some of these patients. And then changes to like the gut bacteria. So like small intestinal bacteria overgrowth or like any bloating or distension there can feel like pain. So patients report this feeling as like heartburn, nausea, pain, cramping, feeling constipated, even if they're having like daily bowel movements. And then sometimes we'll see like this feeling of like incomplete emptying, like patients who are like, I'm in the bathroom for an hour, even if they're not like actually going the entire time. So one of the ways that this can show up, right, is that even the suggestion that food will cause pain in someone who is hypersensitive can increase the visceral pain reaction, right? So if you say that gluten causes pain or is going to increase your pain, it's more likely that it actually will. And again, it's not because it's all in your head. It's because there actually becomes like a dysregulation between like how what's happening in your gut and how your brain perceives that pain. And then same thing if a patient maybe has a negative experience with food, subsequently that food might cause a negative experience again. And I think like we can all probably think about this like if we've had food poisoning or like a stomach bug, like the last thing you ate, like the next time you eat it, you're like, I don't feel right, even though maybe you're not actually getting sick again. But like that feeling is very real. So now kind of this overlap between this visceral hypersensitivity and eating disorders is we can see that patients who score higher on this visceral sensitivity index, it's a 15 question questionnaire, actually have it can predict elevated body dissatisfaction, cognitive restraint, some of these eating disorder behaviors like purging, restricting, excessive exercise. Anecdotally, I can see this as it can lead to like a misuse of laxatives. Like again, patients like never feeling empty, so they're taking laxatives like not prescribed by their MD to try to get everything out. Again, even with a low stool burden. And this I found really interesting, and it's only one study, so I would be interested to kind of see more research in this area. But one study actually showed that early reduction in GI specific visceral hypersensitivity measured by this index during the first month of eating disorder treatment can predict a lower eating disorder symptoms and lower trait anxiety at discharge and 6-month follow-up. And I think that kind of like gives us a real, I find this helpful to kind of note because I think there's probably so many reasons why this happened. And I believe, and this is just my interpretation of this, is that one of the reasons is because when your providers can like really say, like, I believe this pain is real, it strengthens that therapeutic alliance. It strengthens that therapeutic relationship instead of just saying like what I saw in the chat of like, well, you just have to push through it. It's just part of the process, like, etc. And yesterday I was talking to our MD about Dr. Nurko about this talk. And I said, if you were giving this talk, like what would you want dietitians, or I know we have probably a mixed group here, like to take away from it just about DGBIs. And he said, treat the pain, right? Like we have to treat the pain. And I think, we'll talk a little more about why that's so important with this. And I know that as dietitians, we're not always the one in charge of treating the pain, but I think sometimes we can sometimes get like so we can also get so rigid about like what we can and can't do in eating disorder treatment. And sometimes we might actually have to make some nutrition manipulations to help our patients treat the pain and potentially, right, this is my dissertation, right, potentially that can improve the eating disorder treatment at the same time. So that's just something to keep in mind, and I'm always happy to chat more about it. So takeaways from this section are that DGBIs are extremely prevalent in patients with eating disorders. They might predicate ARFID. Malnutrition affects motility. So I think this is something that I want like all GI providers to know. So if you know one, pass it along. And visceral hypersensitivity is very common in those with this overlapping condition. And it's very real pain. It's not all in your head and deserves to be treated. So I'm going to talk a little bit about the treatment approach that we use just when we're treating DGBIs, so you can get a little bit of a sense of that. And then we'll talk about nutrition interventions that can kind of work for both eating disorders and DGBIs. So what I think is important to note is that with a DGBI, the diagnosis is made based on the symptoms. So to treat the symptoms are the disorder, and to treat the symptoms is to treat the disorder. And I say this because I think a lot of patients sometimes are looking for this like underlying pathology. They want to go get a test and see that something is wrong and then have that thing fixed and then be fixed. And unfortunately, as you know, like not the case with this, and it's not the case with eating disorders. Like the recovery process from both is quite a bit of work on the patient's part too. We use the analogy of like a software glitch versus a hardware issue. So there's kind of this, again, miscommunication between what's happening in the gut and how your brain is perceiving it. It's not all in your head, but your brain is like very much part of this condition. And so we kind of use the analogy of like using this multidisciplinary approach to like reset the system. Like when the computer software glitches, we turn it off and we turn it back on. And like I said, like really trying to deliver this message that it's real, it's a real disorder. It's hurtful, but there's nothing harmful happening, right? Like we're not talking about IB, like something like IBD, where there might be something like, if it's not treated, can be a little bit more harmful. So we find that like this treatment approach is most effective when we can use multiple interventions at once. So our, gastroenterologist and our pain medicine physician will use a variety of different medications, which I was maybe going to try to get into today, but I think it would take too much time, and, a variety of different procedures to kind of help with things like pain, nausea, and motility specifically. And then we have our GI psychologist who will do cognitive behavioral therapy, gut-directed hypnotherapy, and then also some exposure therapy as well. We have a social worker on our team, which, for our adolescents and young children are working a lot with the schools to make sure that they have the accommodations that they need, that they're able to actually like get to school in light of all of their symptoms. And if they're not, that they're still able to kind of keep up with their schoolwork and stay on track with that. And then also just like how to engage in extracurriculars and, stay engaged in life. And then nutrition, I am doing a lot of work on addressing malnutrition, identifying and reducing food triggers when necessary, and then to overall like improve functioning around food. I don't I don't know like if everyone here is working with adolescents or if it is just my experience, but the teenagers don't eat lunch anymore. Like that is, I'm just finding there none of them eat lunch. None of them want to eat in front of each other. None of them want to get school lunch, even though it's free here in Massachusetts. So that has been like one of the ways in which I'm like, okay, we need to figure this out. And this is like unrelated to DGBI or eating disorder. This is very much just a social thing that I see happening. Um, I think it's getting stuck. Okay. So we'll talk about some nutrition interventions. So back to this overlap, we have the DGBI interventions that we just talked about, our eating disorder interventions, which I know many of you are familiar with. I think just noting the difference in like the behavior change target is that with DGBIs, there's really this like target of like returning to functioning, returning to life, really making sure that our patients have the tools that they need to like keep going, especially in adolescence, like with school and with, social and extracurricular, um, and to simultaneously work on treating their DGBI symptoms. And the eating disorder target, well, I could argue that like that this could be part of eating disorder treatment too, is really to reduce those disordered eating behaviors. There's some medication overlap in these two disorders, although medications for eating disorders, I I did not work with really any patients in my private practice who were taking medication to treat their eating disorder. It was usually to address anxiety or depression. But I know that there are some exceptions to that. Whereas like with DGBIs, we use a lot of medications to address pain and motility. And then there's some overlap in those medications. Psychology, CBT, ACT exposure therapy, like there's some overlap there. Although I think GI psychology is like a very specific field, and I think it would be amazing if there were like more therapists who maybe like combined the eating disorder and GI psychology aspect too. Um, and then for nutrition, the biggest overlap really is addressing the malnutrition and like really encouraging patients to have consistent meal and snack patterns. But I do think that, from what we know about malnutrition now, like the refeeding aspect um, should really be, in my opinion, part of the DGBI treatment as well. So we know that with refeeding, most GI symptoms improve. Um, I'm seeing, okay, that was weird. Um, yeah, so we're seeing that most GI symptoms can improve with refeeding, but it takes time, right? It can take months for this to happen. Um, Pain and constipation can improve first. Bloating, distension might take longer. And then we also know that some patients develop new GI symptoms during recovery, right? And so I just want to highlight, kind of in light of what we were just talking about with the visceral hypersensitivity, that like just because this happens a lot, it doesn't mean that refeeding is kind of like the only thing that can happen to treat both the eating disorder and the DGBI. I'll just note that I think in our clinic, I tend to feel like I'm the only one emphasizing this. So I'm kind of like thinking about this from both angles. I think that sometimes we could afford to put more emphasis on like regaining weight loss um, with DGBI treatment specifically. Um, so meal and snack pattern. I know that everyone, this is kind of like a highlight of like eating disorder treatment centers. Skipping meals is like very common in patients with IBS specifically because it it hurts, right? Like a lot of times, if you have IBS with diarrhea predominant, even eating like a small amount of food can kind of stimulate this gastrocolic reflex and like patients report, like I'm eating and then I'm like running to the bathroom. So for patients with diarrhea, we can encourage like smaller but maybe more frequent meals and snacks. That has been shown to be like an effective treatment that doesn't involve like eliminating food groups. Constipation, we can encourage like a more adequate meal size. Like the American College of Gastroenterology recommends like a 500 or more calorie meal can actually help like stimulate that reflex. So that's just, something to consider with both of those. And then for reflux, I'll say this is, I actually don't know how much research there is in this. I borrow this a lot from some of our dietitians at Children's who do more enteral feeding. There's been some research to show that the thicker the enteral feed, the more it can kind of help mitigate reflux because it just sits a little lower in the stomach. And so for my PO patients, I might say like, what can you try chewing your food, waiting 30 minutes and then having your liquid? It's not always possible, but if it is, like just doing small sips of water with meals and seeing if that provides any benefit. And then traditional dietary advice, like including this kind of like consistent meal and snack pattern, has been shown to be like on par with a low FODMAP diet. It's not been very well researched, and I wish it would be a little bit more because it, again, is a nice like non-restrictive way to maybe mitigate some of these symptoms. So I am curious, like, does this feel like a challenging thing to do, like identifying food triggers with your patients who like are coming to you for eating disorder treatment? Yes. Okay. I see Monica saying yes. I can't see anyone, so I'm actually just relying on the chat right now. I can only see Monica. Monica says yes. Um, it's difficult when they say everything triggers symptoms. Yeah, for sure. And to be fair, that might be true, right? It seems like it's everything. And I think that's where I think some of this just education is helpful. Like I have always been like a big fan of trying to just tell patients like what it is, like where I'm coming from, what I'm thinking of. And I often do say this to patients, like it probably is everything. We're probably not going to be able to find like the perfect combination of foods to eliminate because everything hurts because of that visceral hypersensitivity, right? And so can we play around with like the size of the meals? Can and also sometimes patients knowing that it's everything gives them more freedom to like try everything because they spend a little less time looking for like what the thing is. Yes, yeah, same foods alternate between being well tolerated and triggering. Yeah, and that's probably happening. It's so here, like it's very, very difficult to identify food triggers, and it is often like a moving target. So, Claudia, that's exactly my point here is that it's very, very challenging. And sometimes like we get lucky enough where we can kind of pinpoint a few foods. And the message I would hope that we can give patients is that this is something we can try temporarily removing from the diet as part of this kind of like resetting the system. If we can kind of reduce the pain triggers for a little while or the symptom triggers for a little while, then we should be able to start adding these things back in if they're foods that you prefer or if they're kind of like a food that's like, providing you with a essential nutrient or something like that. So I think that just kind of patients having this education can be helpful too. Again, low FODMAP diet, this could be a whole other presentation, which I won't get too into, but I will say I very, very rarely will do like the true low FODMAP diet with the patient. I'm really like saving this if like nothing else is working and their diet is like fairly high in FODMAP foods. Um, I find that I also see a lot of patients who come to me and are like, yeah, my gastroenterologist 3 years ago told me to do the low FODMAP diet. I've been doing it for 3 years. And you're like, oh my God, what have you been eating? So just a quick overview. This is 2 to 6 week restriction of these short chain carbohydrates. So you can see here, these are just either producing gas in the intestine or they're pulling water into the intestine. And this is why they can be so triggering for people with IBS. They can lead to like gas, constipation, bloating, diarrhea. I would really hope that my hope is that eventually GIs know that like if they're going to recommend this, they have to like patients really should be working with a dietitian. And the AGA does recommend avoiding this diet for patients with active eating disorders. But like I said, I think I see a lot of patients who are not even like aware that their behaviors around food are disordered. And so this can just be really tricky territory. I tend to, before I do FODMAP, this is not an ad, by the way. I'm just showing you what it looks like. I have no affiliation with this company. But I tend to I tend to recommend digestive enzymes before recommending like eliminating anything. So if someone feels that lactose is a trigger, even if they're not lactose intolerant, I might say, let's try lactate enzyme, or let's try using lactate milk instead of regular milk if that's something that they do, or low lactose yogurt instead of, or like, sorry, a lactose free yogurt instead of um, regular yogurt, or use a lactate enzyme with your first few bites of food. Beano, I use a lot for patients who maybe are eating like a lot of vegetables or beans. And then this FODzyme it's the biggest con I have found is that it's not cheap. It's at cost. But it has the lactase, the alpha galactosidase, and a fructan enzyme. So it breaks down garlic, wheat, and onion. And I don't know if it's a placebo or if it really works that well, but most of my patients that use it say that it's very, very helpful for gas in particular, because it does help break down a lot of those foods. And so if I feel like a patient might benefit from a low FODMAP diet, I'll try this first, because if anything, it will like dampen the effect. And all you have to do is like sprinkle it on your food, which, for like a teenager, sometimes they don't want to do that at school, but that's what they have to do. And then it can help kind of break down some of these foods so they don't have as much of an effect in the GI tract. And then some of these kind of alternative dietary interventions, like besides a low FODMAP diet, might be a lactose-free diet. This has shown to be helpful in patients with IBS, even if they don't have a lactase deficiency. And what I kind of prefer about this for like any other like restrictive diets is that there's so many alternatives out there. Like there's so many lactose-free dairy products, so you could really keep dairy in the diet. And then you could also use like the lactate enzyme if like, they want ice cream or pizza or something like that. And then the one that I do before, if like we've done the FODzyme, I might do like a personalized low FODMAP diet. So look at their diet recall, look at like the most frequently consumed foods, and see if there's any foods we can swap out, maybe like one or two to start, and really make sure that we're like replacing the food, right? So we're not like eliminating it, but we have something that we can actively like put in its place, just to try not to like lower calorie intake at all. And I put a link in my references, but I love the Monash University website and their app for anything FODMAP related. I found it super helpful. Okay, I'm not going to spend, this is another thing I could have talked all day about fiber, but I'm not going to spend too much time on that. For FODMAPs, I always look for like fiber additives or these like fermentable fibers in the diet, specifically inulin and chicory root. They are in everything now. Like any healthy quote unquote food that you can buy at like Whole Foods has these fibers in it. They're not bad for you. They're great for your gut, but they are not good for visceral hypersensitivity because they will cause a lot of gas. So sometimes like I have like really easy, like patients are like, I love that purely Elizabeth granola. I have it every morning. I'm like, okay, we got to find you a new granola because that one has this in it. So sometimes we can like make little swaps like that. Um, and then the other one for just straight supplementation, something you can add is a psyllium husk supplement. So that can be trialed for any type of IBS, whether it's constipation or diarrhea or mixed. And then I just put here, like I always tell patients to make sure they're drinking in a lot of water because that stuff really gels up. Okay, so I talk about poop all day long. I talk about sitting on the toilet. Some of my teenage clients are like very embarrassed by this, but um, I feel like, I don't know, I think as dietitians, we just get used to it. So some of the big things that I might recommend, and sometimes I do this like before changing anything with food, is like don't bring your phone into the bathroom because I'll everyone's doing that now. Maybe people here too, but like try to avoid screen time on the bath in the bathroom, using a footstool under your feet just to kind of get your body in a more like relaxed position. Um, Set realistic expectations for patients. You do not have to have a bowel movement every day. You What is like in the range of normal is 3 times a day or once every 3 days. We have like some cases where patients go like once a week and they're okay. Like it really kind of depends on the symptoms, but I think it's helpful for patients to know that like something's not wrong if they skip a day of having a bowel movement. I mentioned this earlier, but for a constipation specifically, 500 calories or more can induce that gastrocolic response. And then really trying to go when you have to go instead of postponing. And this is something that is very challenging for obviously for everyone, I think, like when you're at work or in public, but for adolescents, like these kids do not want to poop at school. So sometimes with our social work team, like we try to get accommodations for them to at least have access, if possible, to a private bathroom or to be able to go to the bathroom like at any point. I think some schools have like different, I don't know, they have to like ask permission. And I just think that's a little silly. And then sometimes for constipation, I recommend like have the I don't always give them this 500 calorie. I might like talk about meal options that I know are more within that range, and then say go sit in the bathroom for 5 minutes. That's it, no longer, to just relax and see if like something happens, and if it doesn't, then get up. And then same thing for diarrhea. If there's a break in stooling, try to stand up, even if you don't leave the bathroom. But sometimes sitting on the toilet kind of relaxes the pelvic floor, and then that kind of connection between like the colon and the brain just starts glitching, and like we keep feeling like the need to go, even though there's like nothing left to empty. So this return to functioning is kind of what our social work team really works on. But we can see from some of this like pain research that improving in functioning, like going to school, engaging in social life, can really occur independently of like pain reduction. So sometimes we do have to do a little bit like in the wake of pain to then not have the pain anymore. But really this kind of like full approach of like being able to hopefully reduce some of that with medications, procedures, nutrition, and psychology at the same time. So um, I'm going to pause here and like I want to gauge what questions we have, and then I can also go through the case study if we have time, or if everyone's like, no, just keep going, I can just do the case study. But I want to make sure we have time for questions.
Folks have questions if you want to drop them in the chat or even just like raise your hand to signal that you have a question so that Jesse can get an idea.
I'm going to
That
stop
would be
sharing for a
amazing.
second too, so I can just so I can see everyone. Yes, we see this like Laura just said, do you see an association with VH and MCAS? I've not um, looked too deeply into that overlap, but I feel like this is something that we see a lot in our clinic is this DGBI, MCAS, Ehlers-Danlos, POTS, like that kind of trifecta with the DGBIs. Very, very common. Sure. Nicole just asked if I can speak briefly about medications trialed. So we, our GI team often, not with every patient, will use like if it's pain predominant, like a neuromodulator. And it's not for depression or anxiety, it's actually to like treat the pain. So we're like borrowing from that class. And some of the, and then we'll also use like some motility agents. So like motegrity or prucalopride, or it's also called prucalopride, and Linzess is like what we use a lot for constipation. Cyproheptadine, I think, is like more commonly used in adolescents, but it's like an appetite stimulant. It's like a class of allergy medication. And then some of the procedures that are being done is our GIs will sometimes do like post pyloric Botox to like relax that sphincter to just allow for like more gastric accommodation and like treat the gastric, postprandial distress and nausea that can help with. So those are kind of like the common ones, but there's a lot more. Recommended. That's a good question, Alice. Is there recommended manuals or workbooks to address this in therapy? I don't know. I would maybe just look in a little bit more into like GI psychology, because that is like the world in which I believe that there would be something more like that. Um, Specific factors to consider for patients with eating disorders who are afraid of noticing their body while dealing with symptoms. Can you tell me more about that, Amber? You can unmute too if you want to talk to me. I like chatting.
Oh, I didn't know I was allowed to talk. Hi.
Yes, yes, everyone can talk. Please talk to me. Like I've been talking to a well for
Thank
45
you.
minutes.
No, it's just so many of my clients, they're exhibiting these symptoms. I'm a licensed mental health counselor. So, they're exhibiting these symptoms, but they're so terrified of connecting with their body, whether it's, because of the body image distress or maybe specific trauma that they endured that actually like has exacerbated the eating disorder symptoms. So I was just kind of wondering, helping educate these clients who are really suffering with these symptoms, but for those who are so dysregulated by even noticing their body, even though they're being forced to notice it, I was just wondering how you would approach that type of conversation.
Yeah, that's very challenging. So, I mean, great job for even working with patients on that. I mean, honestly, I think that I think it's challenging because sometimes like the treatment is like, how do we actually get you to like notice your body less, right? Like you want to be aware enough of these symptoms that you could get treatment for it. Because I think that what I'm hearing is like some of these patients are just kind of like suffering with some of these symptoms because they're like, I don't even want to talk about them. Is that fair?
Yes, yes. They're
Yeah.
trying so hard to stay in this numb state, which unfortunately many have reached. And obviously I'm trying to help them build some internal safety so that they feel
Yeah.
safe enough to talk to their doctor about these symptoms and whatever it might be that the symptoms are showing up, but they're trying so hard to live in a state of numbness because of that fear and that, maybe body memories, things like that.
Yeah, yeah, that makes sense. I mean, I think that if it were me, and I'm not a mental health counselor, like I think I would actually make that like more, maybe more of like a central part of your work, is like, how do we get you comfortable enough so you can get to your doctor or like make a GI appointment, and we can actually like mitigate some of this stuff for you so it's not just like in the background all the time.
Yeah, no, that's
Yeah.
super helpful. Thank you.
Yeah. Yeah. Yeah, Julia, please unmute. If you don't, no one has to type their questions.
Hi. Um, so I'm a psychologist who works in GI, and then I also work at an eating
Nice.
disorders partial hospitalization program. So
Okay.
this is like a lot of what I see. I see them in
Yeah.
GI before the restriction, and then I see them in eating disorders treatment after they've recovered or after inpatient for medical hospitalization for
Okay.
malnourishment.
Okay.
So a lot of the patients I see in GI, they start restricting because of the pain food causes, and oftentimes they'll feel determined that the foods they are restricting are helpful, and they're very convinced in that. At the same time, they're reporting the same high pain levels, and they'll keep restricting, and they'll report pain is still 8 out of 10, yet I'm convinced I can't add these foods back. Um, and so I'm just curious, how you approach that, when you think it's appropriate to diagnose RFID in DGBIs, and then also how you approach refeeding in general with patients who can't afford to have small meals just for medical reasons. Yeah,
Hmm.
just curious thoughts on this population. It's a lot.
Yeah. These are kind of like all of the same. I'm asking the same questions. I mean, I think it's incredibly challenging because I see that all the time. I mean, I have a handful of patients who are actually on like enteral feeds, which is not really recommended in DGBIs, but as I'm sure you've seen, like it happens when patients are hospitalized. And they're on like the most broken down, like like there's like nothing that could possibly be triggering, right? These symptoms in the formula, and yet they're still having these symptoms. And you're like, if it's still happening with the formula, like we can assume it's still going to happen with the food. And so, I mean, I think it really is just kind of like small exposures of like, in I even if they're not diagnosed with RFID, like that kind of being like part of the treatment model is like, I do a lot of food training of like, okay, here are the foods that are safe for you, you're eating them, is there something that is like close to this thing that we could like then add, and we just do it like really small, like bit by bit. And it's an incredibly long process sometimes, and it's hard when you're like you said you're in a hospital setting and you're like seeing patients like once a month or
Well, when they're at the
less.
PHP, they're there all day, every day
Yeah.
for the
Oh,
eating
right.
disorders
Yeah.
program. But yeah, in GI,
Yeah.
they're there, once, however often. And it's often like they come in and their weight's so low, and the providers are just like, what do we do with this person? They're saying they can't eat because
Right.
of the pain. They're gonna end up hospitalized, but
Yeah.
they're not
Yeah. And I mean,
interested.
I think um what would it yeah, like I think from the RFID perspective, like I would say if there is that fear of aversive consequence, like if I add this food back in, then my pain is going to get worse, then like I would say that is like that's orphan, like that is what it is. And we can, even if we're not the ones diagnosing it, we can kind of start using that treatment model a little bit to start adding some more foods back in little by little. Does that help answer your question?
Definitely. Yeah. Thanks.
um Christy, what did a diagnosis of ARFID do in cases like this? Yeah. Yeah, I mean, I think it changes the treatment. Christy, if you want to unmute too, like I think it doesn't it it doesn't have to change the treatment, but I think sometimes like when a clinician knows that that's what the diagnosis is, it maybe makes it a little bit more like uniform amongst providers.
Yeah, and I guess my question is like what I sometimes, not always, but sometimes see in practice is that patients are diagnosed with ARFID when they are having active symptoms in the sense of vomiting,
Yeah.
significant diarrhea. And can we call it ARFID when it's
Hmm.
significant symptoms like that? I don't know. It's just a
Yeah.
question that always
I mean,
kind of
that's a great question.
doesn't sit well in my head.
Yeah.
I
I
mean,
think that,
sorry, keep going.
oh no, go ahead.
I was going to say too, like, I think part of the challenge with this that I've had is I have had a few patients who have been diagnosed with ARFID and a DGBI, and then, come to find out they end up having deep infiltrating endometriosis. This is one case that I had just recently.
We have a lot of that
And
too.
so they feel incredibly dismissed, and then they're very frustrated with everything because they're like, okay, there was an actual reason for this. Like, this wasn't,
Yes.
yeah. So I don't know.
Yeah. And I will say we've had a lot of cases where we've had that and the patient gets endometriosis surgery and the pain persists,
Yeah.
right? And so and that is kind of like what I'm talking about. I was like, this pathway has like now changed. And so I think it is really tricky because I personally wouldn't feel comfortable calling something ARFID if the symptoms were like that active, right? But if we can start to notice that we're able to like treat some of these symptoms, the diarrhea is less frequent, the constipation is less frequent, the pain maybe has improved, and then there's still fear around food or eating, then I would be, like,
100%.
but
I just think I see, unfortunately, far
yes.
too often that it's diagnosed as
Yeah.
ARFID when they are having active
Yeah.
symptoms.
And it doesn't help that we're like, here's your endometriosis, your OBGYN, your endo provider, your DGBI provider, your eating disorder. Like everyone is like kind of working in their own silos, like looking through their own lens of things, which like we need, but like there's, it's the medical system. It's really hard. Yeah.
Thank you.
I feel like I missed a question earlier. So Jody, in patients with PH, would you discourage using intuitive eating and learning interoception, which might make them more hyperaware? That's a really good question. I think I would. I think in some ways, like I do use some intuitive eating principles with some of these patients where I might say, like, what is like your fullness on that, like using that hunger fullness scale? Because sometimes it is just helpful to notice that it's like the amount of food that they're eating, but they're feeling like it a 9 out of 10. So I think that like some of it might be applicable to use in like more nuanced circumstances. But I definitely have some patients where like I can think of one case in particular that was not an eating disorder, where like part of our work together was like, can you just eat a little bit beyond that like point of fullness? So I think it's helpful for some of them to know, but yeah, with eating disorders, it can be tricky. Anything else? You can unmute too. Okay, awesome. So I know that they're going to put this up on YouTube, or I'll let Monica and Jamie talk about that, but it will be available.
Of course, I hesitate to promise this in case I'm wrong, but either Carolyn or Jamie will correct me. Normally, we will send a link out to everyone who's registered, and you'll be able to link to it and watch it that way. Thank you so much, Jessie. This has been really amazing, and I feel
thank
like
you.
most of us want to make an appointment to consult with you or for our own selves.
Oh, wait, let me actually real quick. I'll share my oh my gosh, now I've lost you guys. My emails, if anybody wants to email with questions or anything like that. So
that would be great.
Yeah, and I'll throw it in the chat too. But for children's, and then I have my personal one. So if there's like any just kind of like case consultation or anything like that, or if you have questions about our program at children's.
So with that, thank you everyone for coming, Jessie.
Yeah,
thank you again.
Thank you. Thanks for having me.
Have a good weekend, everyone.